All right, welcome to the Explainer. I'm your host, and today we're stepping right into the trauma bay to master some really high-yield clinical MCQs covering burn and inhalation injuries. We're using the classic Trauma ABCs algorithm to break these cases down rapidly, focusing exactly on what you need to know under pressure. So let's just dive right in. Now, here's an absolute wake-up call for you. Did you know that 80% of fatalities resulting from fire entrapment in enclosed spaces are driven directly by inhaling superheated smoke, toxic particulates, and metabolic gases? It's not the visible skin burns that get them. To save these patients, we absolutely have to look beyond the surface. We've got to treat the invisible threats. Okay, Section 1, Airway, Thermal and Smoke Injury. All right, here's our first case. What's the most common cause of death in a person who sustains a closed space burn? Is it A, heart failure, B, inhalational injury, C, renal failure, D, cardiac arrhythmias, or E, shock? Go ahead and lock in your answer. And the correct answer is B, inhalational injury. Look, closed space entrapment should instantly alert you to screen aggressively for both upper airway thermal collapse and lower airway chemical injury. The pathophysiology going on here is just fascinating. Smoke inhalation isn't merely a complication, it's an independent negative prognostic indicator that actually spikes overall mortality by 20 to 50%. Why? Because that superheated smoke triggers chemical alveolitis, direct mucosal sloughing, severe bronchospasm, and surfactant inactivation. Basically, the lower airway is literally being destroyed from the inside out. Now, this brilliantly illustrates the sequential logic of airway escalation. Take a patient with suspected inhalational injury, but, no hard obstructive signs just yet. Your initial step? Option B, deliver high-flow 100% supplemental oxygen via a tightly fitting mask to address the acute hypoxia. But if that patient presents with oropharyngeal soot, singed nasal hairs, and visible posterior pharyngeal wall edema, the correct move immediately shifts to prompt elective endotracheal intubation. The absolutely crucial point here is what we call the preventive intubation window. Pharyngeal soft tissue edema tracks a really rapid course, peaking between 4 and 24 hours post-burn thanks to aggressive fluid shifts from our resuscitation. So you must secure that tube early before stridor or hoarseness develops and makes intubation anatomically impossible. Moving on to Section 2, Breathing Toxic Combustion Gases. Which brings us right to those invisible chemical threats. By which of the following mechanisms does the metabolic poison hydrogen cyanide, found in smoke, cause metabolic acidosis? A, inhibition of sodium-potassium pump. B, interference with mitochondrial respiration. C, activation of proteases. D, activation of caspasis. Or E, damaging renal excretory system. And the answer is B. Hydrogen cyanide interferes directly with mitochondrial respiration. Here's the exact mechanism. It's pretty wild. It binds to the ferric iron in cytochrome C oxidase, that's complex 4 within the electron transport chain. This entirely blocks cellular oxygen utilization, completely arresting aerobic respiration and basically forcing the cell into anaerobic glycolysis. And the result? A massive acute lactic acidosis with narrow venous arterial CO2 gaps. Always keep in mind the fire duo of structural fires, carbon monoxide and hydrogen cyanide. If you have a smoke inhalation victim presenting with unexplained severe lactic acidosis or coma, you've got to suspect cyanide poisoning and hit them with the empiric treatment, hydroxycobalamin. Now let's take a look at the other half of that fire duo, carbon monoxide. Let's compare two different CO poisoning cases. In the first one, a 39-year-old male has mild systemic symptoms, headache, dizziness, and a carboxyhemoglobin level of 31%. The correct step here is D, administer 100% oxygen by mask. But what if you have a scenario where a patient has a massive 60% total body surface area burn and requires intubation? The correct step is E, 100% inhaled oxygen. Notice the pattern here? Delivering 100% normal baric oxygen successfully drops the half-life of carboxyhemoglobin from a really sluggish 520 minutes down to roughly 80 minutes. Now, you might be wondering, hey, why not hyperbaric oxygen? Well, hyperbaric oxygen is absolutely contraindicated in a large, hemodynamically unstable burn requiring active fluid resuscitation. We strictly reserve it for severe cases with coma, seizures, or COHB greater than 25% with deep neurological dysfunction. Oh, and a quick clinical pearl for you. Never trust a standard pulse oximeter here. It'll give you falsely elevated readings. You literally must check sequential blood co-oximetry. All right, Section 3, Circulation Systemic Burn Responses. Let's hit you with a physiological exception question. Which of the following is not included in the immediate changes following a burn injury? A. Neutrophil degranulation. B. Shift of intravascular fluid. C. Cortisol secretion. D. Hyperglycemia. Or E. Excessive secretion of hydrochloric acid in the stomach.
The correct answer is E. And this is a really vital distinction. Acute stress ulceration of the duodenum, which we know as a Curling's ulcer, is driven by acute splanchnic vasoconstriction and ischemia of the GI mucosa. It's not caused by an immediate hypersecretion of gastric hydrochloric acid. These ischemic ulcers classically manifest with upper GI bleeding around the 9th post-admission day, which is exactly why we manage them with early enteral nutrition and PPI prophylaxis. The true systemic responses, though, they're catastrophic. We're talking widespread activation of Hageman factor and TNF-alpha, which triggers a systemic capillary leak syndrome within 24 to 36 hours. Plus, you get an acute rise in circulating cortisol and catecholamines, leading to severe insulin-resistant hyperglycemia.
On to the final primary survey step, Section 4, Exposure, Evaluating Burn Depths. Let's start with some surgical foundational knowledge. Which parameters are taken into account while performing skin grafting in a burned patient? A. Presence of inhalational injury. B. Depth of burn wound. C. Aesthetic concerns. D. Age of patient. Or E. None of the above. And the correct answer is B. Depth of the burn wound. This baseline depth is literally the primary determinant for whether we manage the wound conservatively or take the patient straight to the OR. Superficial partial thickness burns, they'll heal spontaneously within 14 days. But deep partial thickness and full thickness burns, those require surgical intervention. We do an early tangential excision, which means shaving down to bleeding viable tissue between days 3 and 5, followed by split thickness skin grafting. The only real exception here is very small, non-circumferential full-thickness burns. We're talking less than 4 square centimeters, which can just heal via secondary contraction from the margins. So how do we confidently tell the difference right at the bedside? Well, for a superficial partial thickness burn, the false statement is that it's anesthetized. Actually, it's quite the opposite. These involve only the epidermis and superficial papillary dermis, which leaves those pain fibers perfectly intact. The classic clinical triad here is exquisite localized pain, rapid blister formation, and a moist, bright pink dermal base with really brisk, normal capillary blanching. Now, a deep partial thickness burn is a completely different beast. A defining feature here is reduced sensation. The burn extends into the reticular dermis, damaging nociceptors and tactile receptors, which significantly impairs pinprick sensation. The wound is going to look dry, waxy white to yellow, with fixed capillary staining and absent blanching. If you leave these ungrafted, they take over 3 weeks to heal and carry a massive risk of dense hypertrophic scarring. All right, let's test your knowledge on a specific chemical exposure. A female patient presents to the surgical emergency after being inflicted by acid. On examination, the skin is black and there is redness of the eyes. What degree of burn will be there in this patient? A. First degree. B. Second degree. C. Third degree. D. Fourth degree. Or E. Fifth degree. The answer is B. Second degree. And the reason simply comes down to the chemistry of the tissue destruction. You see, chemical acid exposure induces coagulative necrosis. This rapidly forms a thick surface protein coagulum, or an eschar. Now, here is what you really need to take away from this. That black coagulum actually acts as a physical barrier. It limits deeper tissue penetration, usually restricting the acid to a second-degree depth. Alkali burns, on the other hand, are way more insidious. They trigger liquefactive necrosis, saponifying fats and denaturing proteins, basically liquefying the tissue matrix and tracking deeply, which often results in third-degree burns. But regardless of whether it's acid or alkali, your primary management step is always immediate, continuous, high-volume water irrigation to dilute and flush out the active agent. Okay, here's our final diagnostic question to round out our burn assessment. Which of the following is not a feature of a third-degree burn? A. Hard leathery feel on burnt skin. B. Charred black color. C. Absent capillary return. D. Visible thrombosed vessels. Or E. Painful skin. The correct answer is E. Painful skin is definitely not a feature of a third-degree burn. This is the ultimate paradox of severe burns, isn't it? Third-degree or full-thickness burns completely destroy the entire epidermis and dermal architecture, taking all those specialized cutaneous nerve endings and pain receptors right along with them. Consequently, these wounds are characteristically painless and completely anesthetized to a deep pinprick. You can confirm the diagnosis right away by looking for the third-degree sign quartet: a hard leathery eschar, a charred black or waxy white appearance, an absolute absence of capillary return, and visible thrombosed dermal vessels. And just as a quick reminder for you, if you see underlying deep structures like skeletal muscle or bone exposed, you have officially crossed into fourth-degree burn territory. So we've covered airway escalation, mitochondrial poisons, systemic shock, and nuanced burn depths. Mastering burn trauma really means understanding that the invisible chemical threats are just as critical as the visible wounds. Next time you encounter a close-space fire scenario, remember, what you can't see is often what's most deadly. Thanks so much for joining me on this explainer, and I'll catch you in the next one.